Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello, everyone, and welcome to today's episode of the Doc Podcast. Over the past few months, we've talked a lot about early treatment and the many reasons why so many of us are so passionate about this topic. As part of that, I've had the opportunity to speak with amazing guests, including Shireen Lim, Stacey Ochoa, Jeff Rothenberg, Rael Bernstein, Dave Singh, Bill Harrell, and Rebecca Bacow about the topics of craniofacial growth and development, the plethora of literature that exists supporting early orthodontic treatment, the role early treatment can play in the improvement of airway patency, the importance of detecting breathing problems and working with our medical colleagues to help resolve pediatric sleep-disordered breathing, and the need to take the time to look at the patient as a whole and not just focus on the teeth or the malocclusion. We've also discussed why so few orthodontists understand these concepts, and despite all the evidence to the contrary, why many still do not believe in the value of or the benefits that can be attained through early orthodontic treatment. Further, we've hypothesized about what we can do as professionals and colleagues to help change that. And that brings me to today's guest, Dr. Dan Grob. Dan is a wet-fingered orthodontist who's been involved in academia as well as clinical practice throughout his career, much as I have. And I really wanted to talk to Dan because he, like most of us, didn't receive much training in early treatment in his residency and was very skeptical of the value it could provide to his patients early on in his career because of that lack of exposure. And that's something so many of us, including myself, have faced. And as a result, he didn't get the opportunity to explore that side of our profession, but that's changed throughout his career. And I'm going to talk with him and we're going to go into some detail on how and why that's changed and how he practices now. Before we dive into that, I want to just tell you a little bit more about Dan's background. So after practicing for 25 years in Tucson, Arizona, he sold his successful practice and moved to Scottsdale, where he opened Valley Orthodontic Group in Peoria. He now focuses much of his practice on pediatric orthodontics, providing treatment that helps facilitate the proper growth and development of the face and dental arches. Dan completed all of his dental, orthodontic, and prosthodontic schooling at Marquette University School of Dentistry in Wisconsin, where he received his Doctorate of Dental Surgery and Master of Science, and received numerous awards upon graduation. He has held many leadership positions during his time in private practice and academia, including as president of the Southern Arizona Dental Society, director of the Cleft Lip and Palate Clinic at Tucson Medical Center CCRS Clinics, instructor of histology and embryology at Pima Community College, assistant professor of prosthodontics, and assistant professor of orthodontics at the Marquette University School of Dentistry. Dan is also a member of the Invisalign Speakers Bureau and the past editorial director for OrthoTown magazine. He's also published articles in the AJODO, Dental Clinics of North America, and OrthoTown. So with that impressive resume and amazing background, I would like to welcome Dr. Dan Grob to the show. Welcome, Dan.
Well, thank you. Thank you for the kind introduction. I'm honored to join the list of other speakers that you've had, because I've certainly followed a number of them over the years, and I never thought myself to be in that same company. But it's very nice, and I'm just kind of working along, trying to do my best.
Well, thank you very much. And part of what I like to do with this show is highlight some people who maybe a little more in the forefront as far as their research or discussions of these topics, and then talk to the orthodontists who are a little more behind the scenes doing this every day with their hands, with the patients, front facing, and those in academia as well. And you have the nice balance that you've really been involved in academia, you've been involved in the organized dentistry side, you've been involved in the literature side through your responsibilities with OrthoTown. You've seen a lot, and you've practiced in different communities, and you've had a really neat evolution throughout your career. And I think that journey and the story of your journey tells a lot about how much we can continue to learn and advance as orthodontists and as professionals, or we have a lot of pediatric dentists and general dentists who listen to the show as well. And it's a journey for all of us. So on that, tell me a little bit more about your journey. I mean, kind of how did you evolve? You've transitioned through your practice career in a couple different phases. So talk to me and the audience a little bit more about those phases of your career.
Well, I'll get to the punchline immediately, and that is I'm living the dream. I've been very fortunate to be healthy, to have a great family, and just experience everything that orthodontics and dentistry has to offer. My wife and I got married in the middle 80s, looked at each other and said, we don't have to live here in Wisconsin. We both want a swimming pool. So we decided to join a high school buddy of mine who had just purchased a practice in Tucson, Arizona.
Okay.
Actually, it was Charlie Tweed's brother's practice.
No way.
Yeah,
Really?
yes, yes. So now Charlie Tweed and his brother were very different.
Okay.
We didn't get Charlie's brother didn't stay up late at night tracing seps. He was typically out on a boat fishing. But I always enjoy telling that story that we bought Charlie Tweed's brother's
Oh,
practice in
how
Tucson,
cool. That is
Arizona.
so neat. Yeah.
So my wife and I moved to Tucson, joined one of my best friends from high school, and we took a very small practice, one office with 3 or 4 employees, and grew it to 3 offices and 35 employees over the course of our years.
Wow.
And if there is such a thing as a wet-fingered orthodontist, that's what we were.
Hmm.
It was a high volume, good fee practice that was across all demographic groups. We had one office located in a very nice part of town.
Hmm.
One office was located in the quote unquote middle class part of town. And one office was located in a neighborhood that was known for probably not the wealthiest patients. The
Hmm.
funny thing is that our treatment, our fees, everything was the same at all 3 practices. And we
Interesting.
became known for that. People came and tried to compete with us. And there were many good competitors in Tucson, but people came and left trying to come up with a different angle. And we really never did have an angle. We just had a great staff. We were committed to doing the best orthodontics we could at the time. We adopted technology, although we weren't early adopters. We were never the first person to buy something. But once it was kind of tried and true, we adopted it and used it. We had dolphin imaging when it just came out,
Hmm.
and we pushed dolphin to the limits, having to create a software program to link our 3 offices using, get this, T1
I
lines.
was just gonna say T1. Wow. Yeah, there's a lot of people out there like T
So
what?
we came to Dolphin and said, we have to be able to have our images available at all the offices.
Yeah.
And what can we do? So they rigged up some kind of an app or workaround or
Yep.
something. We got T1 lines going from this corner of town to that corner of town.
Which were not inexpensive back then to run a
No.
T1 line. It was very pricey.
Well, T1 lines and yellow page ads were very expensive back.
Yes. Yep.
So people that are in practice now that might be complaining about, I don't know, the cost of boosting up your internet to gigabyte speeds or whatever, don't know how easy that is compared to spending literally thousands of
Thousands.
dollars on yellow
Yes.
page ads and
Yes.
T1 lines.
Hmm. Yep.
So
Without a
so
doubt.
that so my point is that we were fortunate to just grow the practice. As things came out, we evaluated them, added them, and we had a very successful practice with 30 monthly payments. In other words, we weren't focused on how long is it going to take, and we'll
Hmm.
parse the payment plan according to that.
Hmm.
We did mainly comprehensive care, not a lot of early treatment,
Hmm.
but we had 30 monthly payments. And I kind of quoted Tony Gianelli had an article in the PCSO many years ago, and he said the best time to start orthodontics is before the 12-year molars erupt and after the first bicuspids erupt.
Hmm.
And everything else was open coil spring in between and gentle expansion and lingual arches. And so we started an awful lot of patients before the 12-year molars were in,
Mm-hmm.
and an awful lot of patients with the E's still in place.
Mm-hmm.
But we managed to get them done in 30 months or less.
Mm-hmm.
And that payment plan seemed to work for an awful lot of patients,
Mm-hmm.
whether they be high income, low income, or whatever. So I've told any orthodontist or young orthodontist that cares to listen that that was the secret, because a lot of them ask, what was your secret? I said,
Mm-hmm.
we just did basic good orthodontics, but we made it affordable.
Mm-hmm.
Uh, there was an outfit called Orthodontic Care Centers, or there was some orthodontic group that started up in the 90s. And I think they
Oh,
started in
OCA, Orthodontic Centers of
OCA.
America. Yeah. Yep.
Yes,
Yep.
OCA.
Yep.
And their claim to fame was, we're going to make it affordable, no down payment.
Yep.
Well, we were doing no down payment in Tucson for years.
Hmm.
We just took the fee, divided it into 30 payments. So when they came to Tucson, they lasted a few months and left. I mean,
Mm-hmm.
because it had been done. We had
Yep.
already set the standard. We weren't in this, well, you have to get a quarter of your fee up front because you spend all that time. And I can go on and on about
Yep.
business and things like that also. But in the end, if you've got a mature practice, it's income minus expenses equals profit. And worrying about a specific fee for each individual patient by the month kind of bogs you down.
Mm-hmm.
So we did very well. I mean, uh, and then we decided we wanted to sell by the time we were 60 years old. We
Mm-hmm.
probably should have done that sooner.
Mm-hmm.
Uh, my advice to a lot of young people these days, and many of them are way ahead of me because of the advent of private equity firms and
Mm-hmm.
things,
Yep.
is that build to sell and sell early.
Yep.
And but have a plan, of course. You just can't sell, work for the company and then look at yourself and say, now what do I do?
Right.
So you have to just kind of keep moving,
Yep.
and we've been very fortunate to be able to do that. We sold to individual partners before the advent of the private equity
Okay.
uh, orthodontic management groups.
Yep.
We sold individually, taking our large practice and selling it off a couple of different ways.
Okay.
My business partner at the time retired, and then I moved up to Scottsdale to do it again and again.
And did you know you were going to do it again at that point, or was it?
Yeah, I kind of knew I still wanted to keep doing it. I
Yeah.
really love this. I'm not
Yeah.
very good at golfing,
Mhm.
so I've got to do something during the day. And if you look at a lot of if you look at a lot of successful business people in the world, if you watch the business channels or Shark Tank or anything like that, you see that people are always kind of reinventing themselves and coming
Hmm.
up with something new.
Yep.
And I've been very fortunate that um, the time frames in orthodontics are like 15-minute increments or half an hour
Mhm.
increments. My attention span kind of mirrors that. So I was very fortunate to find a profession that fit my personality type.
Yep.
And that's been kind of my key.
Yeah.
And I'm kind of academic. I mean, I like to read. I like to know why. I don't like just to repeat things over and over again, which is kind of how I got to where I am now.
Hmm.
You mentioned in my intro um, that I've lived a lot of different practice types, and I
Hmm.
have. And when when I when I was on my third major practice event, which is what I'm in now,
Hmm.
that's when I really changed. And it would have been much easier for me to just hang it up and retire
Hmm.
than to go through all the learning curve of the airway, self-ligating appliances has been tremendously different for me. That's something
Hmm.
I'm between airway and phase one treatment. Um, the biomechanics, the reason for the success of self-ligating appliances really intrigues me. And it's almost like a religion to some people. I haven't taken on the religious bent, but if you bring them up to other people that haven't experienced the benefit of them, they think you're like a cult member or something.
Yeah,
And
I agree with that. And it's very interesting. I always talk about dogma and yeah,
yeah,
that dogmatic thinking. It just goes against my grain because we all have our ways of doing things. And as orthodontists, we're prideful and all dentists tend to fall into that somewhat of a stereotypical bucket that we say, okay, yes, we're mostly type A. We're very particular. We feel very competent at what we do. We've gone to a lot of school. We've been high achievers at the highest levels. And it can be hard to look at the way we do something and think that we could be doing it better. I think by and large that's human nature, but especially in the dental arena. That being said, I find people will almost kind of try to die on this hill, right? Of that they're right over something. And whether that's phase one treatment or not, early treatment or not, or cone beam or not, or extraction or not, or Invisalign or not, or whatever plastic you want to use to move teeth. And so people become very territorial. And you're right, it becomes almost religion, self-ligation or not. And when I'm teaching residents, I'll talk to them, just taking that as an example of self-ligation, and say, I love self-ligating brackets. It's all I used in practice. I'm not going to sit here and say that, it's just because there's less friction and it makes the teeth move more easily. I love the efficiency of self-ligation. At the end of the day, my practice ran very smoothly because of it. I found the teeth move beautifully. It was easy to train clinicians on. It was predictable. You're not steel tying and popping a bracket off at 4:45 when your assistant's like, oh, Dr. Mike, I was steel tying this canine, and the bracket's off. It's just, there's a lot of reasons for it. In phase one, I loved it because it's just easy when you're working on the primary teeth and they get a little loose and you're not tying some O ring over them and making the patient uncomfortable. So again, I go on and on that reason, but at the same time, I tell them, if you want to use a twin to do it, like use a twin to do it. It's up to you. It's what you're most comfortable with. But I find people get so territorial on that. Why do you think that is? Why do you think we are so protective in our profession? Not everybody. I don't mean to say everybody, but by and large, a good number of us are very protective of our techniques and our approaches, and very almost threatened by those who say they're going to do it differently or have a way that works that may be better.
When you started your discussion, you mentioned the fact that we're type A and we achieve and do these things. I think there's a couple of different type A groups in our profession.
Mm.
One of them constantly is striving for the attaboy, the badge to hang on their wall, the gratification from someone who they always looked up to as gee, if I would only please this person. I think some of these people feel that they've latched on to a quote unquote guru of sort, or perhaps their department chairman or their mentor,
Mm-hmm.
and would not want to go against that grain. Then there's others, and I think they're equally talented and equally justified in saying, darn it, I've got my degree, I learned the basics, I can think for myself. And they think out, and I like to think that I'm in this group.
Mm-hmm.
I was in the other group for a very long time.
Mm-hmm.
I mean, I've achieved like a lot of badges, but now I'm saying, darn, I've got 40 years of experience behind me. I've seen this, I've seen that. This works, this doesn't. Why didn't this work? I'm really questioning myself, questioning decisions we've made in the past. And I think we have to feel self-confident that we don't need anybody to pat us on the back and say, you did a great job.
Mm-hmm.
I'm at the point now where I feel, I've had a lot of experience. I've seen pretty much a lot of things and or seen it all. And I'd like to share it with people. And back to the self-ligating, my staff loves self-ligating, and they were with me, this group of 10 that I have now, they were with me when I made the transition from twin brackets, the best brackets on the market, not the dollar ones from overseas,
Yep.
a great branded twin bracket, to a inexpensive self-ligating, to now the creme de la creme. And they appreciate it. And they know that, boy, Dr. Grob, we finally are rid of this mishmash of brackets that we have in the practice. And we still have some twins. And if I have to retreat 6 lower front teeth, sometimes I'll put those on or something. But for the most part, we're a self-ligating practice now, and they love it. And so do I.
Yeah.
So that it's,
I don't really know many who have gone to self-ligating that have given it a chance. I mean, if you just tried 5 cases, it's one thing, but if really given it a chance, I really don't know of many who have said they don't. And analogous to that is cone beam and early treatment. Like, I really never met people who have taken those leaps and said, geez, I don't like doing that, or I don't see the benefit of that.
Right.
That doesn't make me a better practitioner. I'm not saying no one has said that, but I can't think of anyone off the top of my head. And it's actually quite the contrary. I find anybody who says, much like yourself, myself, geez, I didn't always do it this way. I wasn't trained this way. But boy, I cannot believe the difference in what I'm doing. So for you was just taking, let's say, like the phase one side of things, the early treatment side. Was it a gradual progression? Was it more of an epiphany where you just kind of read an article or saw cases and realized, hey, look, this is something that I haven't been doing that I should? How did you get later in your career, which I give you tremendous credit for, because so many people, there are young docs who aren't willing to make those changes and are not willing to be as critical of the way they've done it and look back at their body of work and say, hey, I could do this a little differently, and that's okay. Doesn't mean I was bad in the past. It just means that this is an evolution. So for you, was that something that just kind of happened, or did you have to take a series of years to evolve into that? Have you heard about the doc community on Facebook? It's where you can get access to more great content, including case reviews, select clips from CE courses and podcasts, literature reviews, and exclusive promotions and discounts off doc educational materials. Just go to Facebook and search for the doc community and submit a request to join the group. And now back to the podcast.
Well, I was kind of forced into it when I made the decision to join a pediatric dentist. I had a couple of patients. One was there was a young couple, husband and wife. They were both dentists and cosmetic dentists from New York. They moved to the town, and their son had been set up for serial extraction. All four C's had been removed. The spaces were closed between the four anterior teeth and the D's. And they kind of came to me and said, our son is set up to have his four first spies taken out. What do you think? And I kind of looked at, and I kind of took a step back, and I've been watching faces for a long time. I kind of looked at him. I said, geez, this just doesn't look right. I think his smile was narrow. Plus, both the parents were over-the-top cosmetic dentists that do full face reconstructions with teeth, opening verticals, 12-tooth smiles, that kind of a thing.
And I'm sure the patient, their son's bite was 100% deep and flat, obtuse interincisal angle, retrocline dished in inside. I can picture it, like what every sort of serial extraction case looks like when the C's have been removed and the incisors have taken the space.
Teeth were relatively upright, and like I said, there were no space. So I said, well, let's try this. I said, well, we'll put a 2x4 on the upper, a lingual arch on the lower, and see what happens. And what happened was, and I don't know if you think like this, but I think like this. When you have a 2x4 with open coil spring between the four front teeth and the molars, the open coil spring in between, it holds the cheeks away from the alveolar arches.
Without a doubt.
So I almost call it a poor man's Frankel appliance, where
or like the lip bumper philosophy on the lower, right? Holding that. Exactly.
So we just patiently watched the C's and the D's and the E's fall out, the permanent teeth erupt. And the before and after picture from that treatment that we finished with and how we started is amazing. And the teeth were not flared; they're upright. It was a gorgeous smile.
I had almost the exact same circumstances, except mom and dad weren't dentists, but they were prominent people in the community. I was early in my practice years, starting to realize, geez, this way of just kind of pulling teeth is just I'm not liking the way this is going. And this patient had come from another orthodontist, and they came to me, exact same spot that you said. And they said to me, is there anything we can do? They were very image conscious, not in a negative way, right? They wanted their daughter to have a beautiful smile. And I looked and I was like, it was one of those landmark cases where I said, pulling the primary canines is not treating the etiology on this patient. It simply isn't. It was treating the symptom. And I can picture her arches vividly in my head right now. And I looked at her and I said, at the very least, let's just try to normalize like her narrowness and her retroclined incisors, the fact that her incisors, because they came to me saying her front teeth look like they're like going backward, and they just kind of didn't like the way that looked. And so I said, well, I'll tell you what, the least I can do is, and she had all her D's and E's. And I said, let's just go ahead. And at this point, I wasn't doing it with braces. I was doing it with expanders and trying to experience. I wasn't really settled into a technique at this point. I just like you know, it's like, 2x4 lingual. Let's see what we can do to kind of make some space in there. And next thing you know, I'm going through this and space is opening up and her incisor inclination is improving and her smile architecture is improving. And I'm going, wait a minute. But I was treating the etiology, right? I was actually solving the problem instead of treating the symptoms. And that's so funny that you had a particular case that taught you the same lessons. And I think that's what's so valuable about it is, and I encourage all young docs, all docs, period, but especially the young docs, be willing to step outside your comfort zone a little bit and say, hey, let's give this a shot. Maybe it will work, maybe it won't, but I'm not going to hurt anything, because I learned so much doing it that way. And it sounds like you could have very easily said to those parents, look, those teeth are pulled and that ship has sailed, and this is where we're going. But you were willing to take a step and a leap and try something, and look what happened.
That patient was treated probably 15, 20 years ago.
Same with mine. Yep, exactly.
And,
Yep.
and I still have all the digital images in a slideshow presentation that I show parents when they come in, and I said, this is what we've done in the past. This is how it turned out. No guarantees, but it does work sometimes. And which leads us into the next topic. So you have to have lip closure, tongue has to be on the roof of the mouth, nasal breathing. All of those factors are why that worked. And
you got it.
And that's again why we're talking about this today. But there was a case where he had no oral habits. He was able to breathe through his nose. Tongue was on the roof of the mouth, and that's what allows those cases to work, I believe.
I agree with you.
I don't know where you want me to start to get on my lectern, but
right there. I mean, so once you started realizing it, and then you were kind of forced more into it, like you said, in after you made the move and you're with a pediatric practice, which is another little aside. I do find that the pediatric dental community and the general dental community, and this isn't a slight to our orthodontic colleagues, but they definitely have been more receptive and open as I've been public about this and talking about this in a web-based format. Get a lot of feedback from people. And I find that the pediatric colleagues and general dental colleagues, by and large, are seeing this more than the orthodontists are. They're more open to it. And my theory is that they're just exposed to it more because they treat more young kids than we do. You know, most of us come out of residency and we've never really treated a kid, seriously, even 7. I mean, you ask most orthodontic residents graduating from programs in the US today, you ask them, how many kids under the age of, let's say 9 even, right, have you treated orthodontically? Right. It's going to probably be able to be counted on one hand for the vast majority of them. And it probably was like a crossbite case they put an expander in, or maybe they got the opportunity to use like a face mask on a class 3. But other than that, they're not exposed. Whereas the pediatric dentists and the general dentists, a lot of them are in their residencies and they're training, they're treating younger kids. So they're a little more hyper aware of this. And the other side, I feel, is, I'd like to hear your thought too, is especially the general dentists, they're seeing the breakdown in these patients when we don't treat the occlusion, the etiology. I've had multiple on the show talk about the fact that general dentists have seen this down the road and said, geez, when these patients are 30, 40, 50, 60, the occlusion is just so compromised because that etiology was never addressed and the arches didn't develop properly. And you have these narrow arches with a steep curve of Wilson and a deep bite and all the wear and attrition that's happened and parafunctional habits and TMD it's associated. So I don't want to go down the rabbit hole of, whether you extract or don't extract and expand or don't expand, you lead to that. But my point is there's a lot more happening than just treating the teeth of a 12-year-old to 14-year-old that a lot of us are taught to do in our training programs.
So true. I was very fortunate. Well, back to our patient of 15, 20 years ago. Mm-hmm. So when I was on the verge of selling my Scottsdale practice, and I said, okay, I still want to keep going, but I'd like to partner up with a pediatric dentist. Mm-hmm. I approached a young pediatric dentist who had opened up his own office after being an associate in a practice. Mm-hmm. And I shared with him that patient. Okay. And I had a little slideshow or some laminated slides or something that I said, this is what I do. I said, this is what I believe in. I know you're coming from this practice where an awful lot of primary teeth are removed, an awful lot of 4 bicuspids are taken out. I said, but I believe in this. He sat on it for 3 to 6 months. Kind of stalked me, talked to a few of his classmates, found out that I had treated one of his classmates in Tucson, knew that I was a reasonable guy, and I was in partnership with another orthodontist for 28 years. No litigation. We still call each other on the phone. That says a lot, I think,
Yes.
about me and my
Yeah.
business partner.
Yes.
That we said, okay, we're selling, we're breaking up, it's all done. Life was great, you know.
Yep.
So he thought about it for a while. Then he offered me the chance to come in
Mhm.
with him. So I said, this is how I'm going to try to do this. So I basically was thrown into a young pediatric office.
Mm.
I rented a couple of chairs. We had a business relationship worked out,
Mhm.
and he started flipping over these, 7 and 8-year-old and 9-year-old patients and say, okay,
Mhm.
what are you gonna do?
Yep.
So I started expanding them. I mean,
Yep.
I had no formal training in this. I
Mhm.
was putting Haas expanders in. The mothers or the grandmothers were getting the keys stuck and they fell
Mhm.
out. I mean, we were pretty much, because now we were doing it more than just 15% of the patients. We were
Right.
doing you're getting expander, you're getting expander.
Yep.
Uh, the first thing we decided to do in that practice was buy a cone beam.
I was
And
going to ask you about that's interesting. I was going to say, where in this did cone beam come in? Yeah,
yeah,
tell me about that.
cone
Yeah.
beam was the first purchase that we ponied up money for.
Okay.
We bought one used from uh, Renew Digital. I
Yep.
remember
Yeah.
that. We got practically a brand new one for a reasonable cost, installed it, and once again, I just kind of learned on the fly, read the
Mhm.
manuals. I actually flew out to San Jose to visit the software company that
Mhm.
runs the ICAT um, anatomage. And
Yep.
I sat down with some of the technicians there, and they showed me the features of the software and how we could superimpose and how we could make videos, and we
Mhm.
did all that stuff. And so I basically just kind of self-taught myself.
Yep. Same.
Um, the whole analysis of airway and nasal cavities and upper and lower pharynx and things,
Mhm.
that kind of came with time. At
Mhm.
first, I just had the cone beam. We were, cutting a pan out of it. I really wasn't aware of all the features. I'm still
Mhm.
learning more every
Mhm.
day
Yep.
that we spend more time looking at the cone beams. But that was the first purchase. Of course, we used the low dose radiation.
Yep.
I felt
Same.
comfortable with the low dosage of
Same here. Mhm.
radiation. Uh, I think that Sean Carlson, I attended, are you familiar with Sean?
Yes. Yep.
Sean Carlson, you lectured with Carlos Quintero out of Miami
Mhm.
uh, for a while on cone beam and adopting it. So I attended a couple of those classes. Uh, and he had a big phase one, phase two practice in Sausalito.
Mhm.
And I remember at either the beginning or the conclusion of his lectures, he would show 100 consecutively treated cases, and they would flip through very rapidly. And
Mhm.
they all looked gorgeous. Oh,
Mhm.
midline was off here, maybe this or that. But I mean, as far as face and smile, these
Mhm.
patients look great. And I said to myself, I want to do that.
Mhm.
And
These were phase ones that he was showing.
well, he was showing pre-phase one
Mhm.
and the final results
Yep.
after
Got it.
phase two.
Okay. Got it.
So, but they were gorgeous,
Mhm.
and um, I don't think there were any permanent teeth removed in the bunch.
Mhm. Yep.
Maybe a couple, but I said I want to do this. This
Yep.
this looks like he's not violating any principles. The
Yep.
teeth were sticking out.
Yep.
There wasn't excessive flare, which is another aside. There's another prominent pediatric dentist in the community here who I approached, and I said, "What bugs you the most out of about orthodontics?" She says, "When
Mm.
the teeth stick out."
Mhm.
And so she said protruding teeth. So, you try to take a non-extraction case and turn it into, or an extraction
Mm.
case and turn it into non-extraction. And all you do is open coil spring and flare the teeth.
Right.
You haven't done anybody any good.
Right. Right. And that's
So,
such a great point because it comes back to my one of the fundamental principles that I speak about, the way I practiced and the way I teach is I just actually put a post in the doc community today about diagnosing the etiology. And if you're just trying to do it to not pull teeth, it's just as bad as doing it to pull teeth in the sense that if you don't look at why you're doing it, so if they're protrusive and you want to try and crowded and you want to try to avoid extracting teeth, well, why would you make them more protrusive if
yes.
that's violating, the like you said, the biologic principles, the bone, the gingiva? Conversely, if they're narrow and dished in and crowded, why would you solve it with extracting teeth instead of normalizing the transverse and the incisor inclination? And oftentimes, as I'm guessing the case is Sean showed that you're indicating, I don't know, but just by the way you're describing it, sounds like those were cases that could benefit from developing the transverse and we're not being overly protruded. The incisors weren't being overly protruded because you're diagnosing the etiology. And I think a big part of it, number one, was what I said before about the lack of exposure to young kids that orthodontic residents get. I think another big part of it is we kind of fall victim to that fast, quick, like you said, like 15-minute visit. We rush through our consults a lot of times. And I think we don't even learn necessarily in school. When I teach, I do like to teach a lot about the consultation process to the residents and help them understand how to do this in the real world. Because in a school, it's a totally different process. It's very formal.
Yes.
It's long. It's multiple step, 2 or 3 step processes. And then all of a sudden you get out of practice and it's like, whoa, you have to figure this out on the fly. And I think you almost default to like, well, let's just like pull some teeth because it looks like it's crowded and put some braces on because I know how to do that. Instead of really working on your on the fly diagnostic capabilities, because Bill Harrell, who's on the show just recently, said it very well. And he's an orthodontist in Alabama, has done some amazing things in the airway arena and 3D imaging arena through his career. And he also teaches at Alabama, Birmingham. And he talked about, they need time in residency to learn how to straighten teeth. It takes time to really learn, and you have to follow a case over a couple of years a lot of times. So they don't spend as much time in the practicality of how to figure out what you're going to do on your patients on the fly in a busy orthodontic practice.
That's right.
And as a result of that, I think they make mistakes in the diagnosis. And I really don't believe that it's, there's any ill will or malice. I really don't. I feel it's just maybe a little bit of ignorance in that they've never been taught this, a lack of education. And you just kind of fall victim to it. And because it's not a life or death decision, if you were doing this as a physician and it was the medication you were going to put the patient on or the surgery they needed or didn't need, there are real severe consequences that you're going to feel right away. That's not the way it is with us. Like, okay, so you extract some teeth and maybe that patient has an underlying airway issue that you never recognized because you didn't take the time like you did, like I did, to learn about 3D imaging and cone beam, things we never were taught in our residencies. Understand airway and what's going on with the nasal passageways and pharyngeal airway. Start to look at some of these things. There's no real direct, immediate consequence of that, right? So you send the patient to get some teeth out, you straighten their teeth, and you can maybe make the teeth look pretty good in the end. But if you miss the etiology of that transverse deficiency, which oftentimes can be, not always, but can be airway related, that problem's not going to show up until that patient is long out of your practice. Now, I should say they may have some of the symptoms and signs that you should recognize, the narrow arches and the mouth breathing and the snoring and the ADHD-like behavior and so forth. But it's not like that's a life or death thing at that time. And so I think that's one of the hardest parts about this when I teach this is how do you get people to realize that when you're looking at that patient in your chair for that first visit, if you miss some of these things, there are real consequences to this, more than just because you can straighten their teeth really either way, right? I mean, as long as you have a reasonable idea of what you're doing orthodontically, you can get them to have straight teeth and maybe a class 1 occlusion with ideal overbite and overjet. But which person did better for their patient? And so I think that's one of the things that we struggle with as a profession is we don't have that immediacy of that immediate consequence that we face. I don't know. Do you think that could play into it at all?
I agree. Which is probably one of the reasons we don't have production goals in our practice. There's good and bad to that. We do very well, and we're growing every month, every year, every month on month. But I've never sat the NPC down. I mean, we follow the closing rate and things like that.
Sure.
But I've never said we've got to produce this. We have basically grown into a comprehensive exam protocol that treats everybody the same. The 6-year-olds, the mothers and fathers of these kids that are in their 40s and 50s, and then the grandparents. We do it the same way. We start with the face, work in,
Love it.
and finish with the teeth. And that is for the well-educated and parents and patients that are searching, they realize that you're putting some time in. And story from last week, putting some braces on some kids. She says, just so you know, I'm sending all the neighbors. So-and-so just had his tonsils and adenoids out. No more night terrors, no more snoring. We don't have to rent two hotel rooms when we go on trips. All of these. Now
Life changing. Life changing.
life changing.
Yep.
And she stood up in the middle of my clinic and was shouting this so
Yes.
every mother in the place could hear it.
Thank you
And
for telling that story, because anybody who's done what you're doing knows that exact scenario. And I love that you just had that happen. And I hope it can encourage more people to do what you're doing. But go ahead. Sorry.
it happens almost weekly.
Yes.
Where someone comes back, or you get a letter back from the ear, nose, and we get all the correspondence with the ear,
Yep.
nose, and throat doc,
Yep.
because I've got a good one that I work with. He sends me all the office notes on when he prescribes Flonase and when he thinks the turbinates need fixing and things like that. But all it takes is a few life-changing experiences like that for patients, and you realize I'm really doing something good.
Yes.
And rather than thinking about how many braces sets you put on that day, you think, boy, I saved this kid and I got this one, and the mom really thinks this is great.
Yeah.
And it's unfortunate because, as you know, you send a lot of these patients back to the pediatrician. Well, they don't have too many strep throats.
Right. They've had 5 strep throats this year. No, so we're not going to do anything. Yeah. Yep. Been there.
We have 3 kids, and one of our own daughters was supervised like that into college, and finally she started missing so much school she had to go in as a college age girl and have her tonsils and adenoids removed, which was awful.
Brutal.
So if we can save many of these young kids from that pain and morbidity, that's really helpful. So we have stories like that all the time.
It's so wonderful.
It's just great, and like I said, my exam starts with the face, works inwards, and I've just added more and more features as I feel comfortable with the software, and as I feel comfortable speaking to them about certain things that I find, and ask your ear, nose, and throat doc about this. I noticed this, and check this out, and it becomes its own self-propagating marketing program.
Yes, that's such a great point too. Yes, yeah, because do you have the situation where like they're taking their cameras, their phones out and filming you, showing that, or taking pictures or stills or whatever of
all the time.
And then
why didn't our pediatrician bring this up? Why didn't so-and-so bring this up? I said, they work under certain guidelines.
Yep.
I said, we've developed this plan. I'm not forcing anything on anybody. I'm just saying I'm observing this. This is what we do. And I love it. It's the best feeling in the world, because like you said, you can put braces on everybody, you can make their teeth straight. That's all nice. But I mean, when you start picking up these issues, and I don't mark it as an airway practice.
No, never did myself either. Yeah, no, you don't have to.
It's just part of our exam. We look at these things.
Yep.
So and you brought up the general dentist and the pediatric dentist. It seems like more of the courses seem to be taught by well-educated general dentists and pediatric dentists, because maybe there is a void in our formal education system. I don't know, but I've been attending a lot of the classes. I spend big money to go to these, some of these people, and spend a day or two and basically get the research, and I go through that and say, okay, are they pitching something that's pretty legitimate or not? So that's kind of how I'm doing it.
And for that, and I love that you said you start with the face and go inward. That's how I teach in my courses. That's how I teach when I teach residents. And I think that's so, honestly, I don't know many residency programs, and I'm not knocking orthodontic residency programs.
No, I know.
I'm just trying to call balls and strikes and point out the problems that I see, because like you and like so many others I've had on this show and spoken with, even off air, so to speak, they have the exact same stories that you just told. And as you're talking and telling those stories, I can picture myself in my practice with the parents saying those things to me and having those conversations, and people breaking down literally into tears, and mom saying, why are you the first one to figure this out about my child? Why? My kid has been suffering for 8 years, say the child 8 years old, and I knew something was wrong with him. And as much like you, I just say, look, everybody has a different approach. This isn't a technology that we've invested in, and it's a passion of mine to start to look into this. It's not really the norm in our profession yet. So all we can do is just keep talking about it and keep trying to educate. but still so many of our colleagues are resistant to it. And again, I don't want to go too deep in the weeds here on why. But I think ultimately what's interesting is, number one, as we alluded to before, anybody who does it and is doing and having the experiences that you so well described, there's no way you're doing that and then go, yeah, I don't want to really do
Yeah,
this
they don't go back
anymore. Yeah, it really kind of sucks that I just saved that kid's well-being in life and family life and everything else. Yeah, right.
Yeah.
I mean, it's so that I don't think I've really ever met anybody who says that. The other thing is people say, well, there's no research. There's no research. Well, number one, the empirical data and the anecdotal data are significant and relevant, right? If you can show, if multiple of us in practice can show multiple patients we've done this with, right, that does carry some strength to me. That's not maybe as robust as, say, some study which Bill Harrell again was talking a lot about, why it's logistically very difficult to run these longitudinal studies on this specific topic. And he's working on some really cool things with the ADA and Steve Carstensen, Jerry Simmons, and Karen Parker Davidson, and they're trying to do some really neat things. And I'm actually going to look to get them on the show to talk about some of those things, to try to quantify this a little bit more. But the evidence, I mean, we've known going back to early 1900s. Engel talked about mouth breathing being one of the most severe causes of malocclusion.
That was written in 1907.
1907. Yeah.
I have that quote laminated, and I show it to parents regularly in a little binder, our new patient binder. For those listening to this podcast, you can download Engel's textbook on Google. It's free. You like the etiology of malocclusion, 1907. It's a PDF. You download it. And I found a screen capture someplace that quotes Engel, where he says mouth breathing is the most prevalent, long-lasting thing that can cause malocclusion in the world.
Right. It's like, of all the causes of malocclusion, like, so the mouth breathing is the most severe, something to that effect. And it's unbelievable that we've known this for over 100 years.
And that quote was never brought up to me in my residency.
Me neither.
Here is the quote.
If you have questions about a clinical case, or maybe a challenging practice management issue, or maybe you're a new doc who's starting a practice and doesn't know where to turn for advice, Doc's private one-on-one coaching platform is here to help you succeed in all these areas and more. Just go to theorthocoach.com and select coaching from the menu to enroll. And now back to today's podcast.
Of all the various causes of malocclusion, mouth breathing is the most potent, constant, and varied in its results.
There you go.
So, and that's
there you go.
It's actually a laminated quote that I show the parents when I'm doing the exam. And I said, the guy that invented orthodontics said this about mouth breathing.
Yep. And Bill Harrell sent me an article from Albert Ketchum from 1912, which the Ketchum Award, that we give at the AO.
Yes.
So Albert Ketchum, same thing. He went into great detail on the impact of mouth breathing in the etiology of malocclusion. E.A. Bogue, I've quoted on the show many times, 1913, was treating the deciduous dentition because he felt that the lack of space for the tongue was altering the growth and development of the craniofacial complex. And so, I mean, we've known it's there. Anybody who does it is passionate about it. Yet there are still so many people who throw so many arrows at those of us who are trying to advance this technique and this approach. And interestingly, though, I've never seen any of those arrows from anybody who's ever tried it. And I often say, and I mean this, and I don't mean this in a flip or condescending way. I really don't. It's sincere. I do feel badly for those who won't try this type of approach to treatment, won't embrace the concept of treating patients younger when they're earlier in their growth and development, in the early mixed dentition, or some are even advocating for the primary dentition, and starting to, at the very least, look at these patients as you look at them, as I look at them, and say, more is happening. Look at the face, get a cone beam, look at the 3D image, understand it, pick the minds of your ENT and allergy colleagues, and start to understand this, because I've never found anybody who's taken that leap and has regretted it or felt like they weren't doing more than they were doing when they were straightening teeth. And I don't mean to minimize the straightening of teeth. We do amazing things. And as you have been very fortunate to create a lot of amazing smiles that I'm very proud of and change lives in that way. I didn't learn anything about how to change them with interceptive treatment, though. At the very most, it was, oh, yeah, I got to get them out of crossbite. And I'd like to talk a little bit about maybe how we can solve this. You're in academia. I'm in academia. You have a lot of years in private practice, as do I. We have a similar journey that we really never really learned about this or knew about this. And we kind of self-taught and just started exploring and trying things. And we both become very passionate about this. The problem is it really isn't changing on an educational stance. Some schools are. There are some schools, again, not referencing my interview with Bill, but Bill talked about at UAB, they are being more open to this and looking at cone beams and airway. I know with what Audrey Yoon's doing in Stanford, they're doing more with this, and there are small steps being taken, but the general orthodontic establishment has still not embraced this and accepted it. And one theory, which I'd love to hear your thoughts on that I have, has to do with the Salzman index and the fact that most orthodontic residency programs are treating patients who their patient demographic is patients who are on state funding and Medicaid. And how do you determine if they can have treatment covered? You have to do the medical necessity Salzman index. You score it, and it's whatever, 26 points or whatever the case might be. Quote me on the exact number, but if they don't meet that criteria, then they don't get coverage, and they don't count the primary teeth in that index. So the only way you can get coverage if you are in the early or mid-mixed dentition is if you have a posterior crossbite that is determined to be skeletal in origin. But as we both know, and I haven't talked about this directly, but just hearing what you're saying, I know that I would be willing to bet you agree, is a lot of patients who present with no posterior crossbite at 7-8 years of age have a more severe malocclusion. I've read some of your content that right, alludes to that as well. Some of the articles you put out there that you have this patient come in with no posterior crossbite, but they've got a narrow mandibular arch and a steep curve of Wilson and a deficient maxillary bone width relative to mandibular bone width. Those patients you are essentially at that point, they have moderate to severe anterior crowding. Again, etiologically, it's because of the transverse deficiency. You're forced in most residencies to start pulling teeth on those kids. And until that index changes, and again, because most residencies treat a high percentage of their patients that are on state funding, and the state is the gatekeeper, they don't have a chance to treat these kids. So to even say that, and then if you're a director in a program or someone who is administrative within a program, you don't have the cases to even teach your residents, and you've never even seen this happen or work, right? So now you would have to go back on all of your philosophies and approaches to patient care. And I think that's our biggest hurdle. I'd love to hear your thoughts on that.
Well, I agree that the formal orthodontic education system is probably a big hurdle to moving fast. Maybe we'll get there eventually. Mm-hmm. But doing like I said, so I've been in practice 40 years. Maybe the first 30 or so were traditional, just like I was taught in school, orthodontics. Mm-hmm. It's been the last 10 years that I took it upon myself to learn these things with the advent of new technology. Mm-hmm. If you look back over the 40 years, there were always big leaps taken with technology. And the early adopters were always accused of overutilizing that technology. Mm-hmm. And then eventually it takes kind of a little step backwards and becomes sort of mainstream. Probably panoramic x-rays. I even believe that the lateral head film was over the top when it was introduced. Mm-hmm. I've seen a lot of different technology. When I moved to Tucson in the 80s, they were using what's called a quintsectograph.
Quintsectogram. Again, Bill's episode keeps coming up. Bill was talking about the quintsectogram. Yeah. Yep.
And that was at the time, there were a couple of kind of litigious orthodontists in Tucson that were claiming that, doing orthodontics this way or that way, or for one, taking out teeth. Because remember, I was from Tucson with Charlie Tweed.
Right.
So there were a lot of 4-bys missing in Tucson.
Yeah.
So there were some lawsuits and things related to TMJ, and a couple of the orthodontists, and an x-ray center developed with a quintsectograph. Mm-hmm. So I remember going in on Saturdays with my business partner and looking at all these lateral head film, these quintsectographs, and the joint is a little bit behind, and there's beaking, and this patient's got TMJ problems, and we were trying to like second guess what we were going to be sued for. Mm-hmm. So anyhow, that was one piece of technology. Another thing was, I was kind of part of the whole Roth Williamson thing for years too, with articulated study models.
Yeah. Yep.
Now, I still really believe in that, and
Mhm.
I can't tell you how much I learned from mounting all of our patients on
Mhm.
articulators. It's probably not as important or taught these days, but I still think it's a valuable thing to do. Other technology, probably lasers.
Mhm.
We do a lot of laser gingivectomies. I
Mhm.
don't know how
Yep. Yep.
popular that is in dental schools, but I don't think it is.
Nope.
Um, so it actually takes people like you to bring this to the forefront. Me a little bit by writing an article once a year on my experiences.
Mhm.
I've tried to nudge my former or the school where I was educated
Mhm.
into adopt this. I found out from the fundraiser there that the orthodontic department doesn't talk to the pediatric
Mm.
residency program at Children's Hospital. They're
Think
too
about that. Oh,
uh,
that's just like
which blows my mind.
oh. Do you know why did they say?
So
Was it just adversarial relationship or I mean
I don't know, but there's a pediatric residency at Children's Hospital in Milwaukee. There's a dental school with an orthodontic department at Marquette, and the two they shall not meet or talk.
oh.
I tried to negotiate a meeting 1 or 2 summers ago. The meeting was canceled for one reason or another. We never got it back. I put up the money for a cone beam X-ray machine. It's
Mhm.
been 2.5 years. I just looked up the date. It's still not installed.
Mm.
Um,
And probably because they don't know how to, if I can guess from my experiences, they don't know how to integrate that. They don't know how to
that's
bill
right.
for it. They don't know how to who reads the image, how they
That's
get the
right.
reading from the OMFR to the students. Because I've found that in a lot of these schools, it's a logistical challenge, and
It
it's
is.
right and this quagmire of logistics that they find themselves in trying to decipher. And in meanwhile, there's these patients suffering, and I mean, I'm thinking, especially like cleft craniofacial and all of the things you can detect in working with your otolaryngological and allergy colleagues, and you're all under one roof or the auspices of one entity, being that hospital system. How are we not talking? How are we not communicating? And there's got to be a better way to do it, because think about that. You're willing to fund a cone beam, but they can't figure out a way to use
Where to
it.
put it? Right now they're kind
Oh,
of fighting over which department houses it, who gets to use it. I've made some comments saying, well, software is kind of specific to the specialties. I had a root canal done. I don't know if you've had a root canal done with a cone beam X-ray machine, but it's over the top amazing
mm,
what the endodontists do these days with a cone beam. Narrow field of view, high resolution.
mm-hmm.
The whole thing's done on a cone beam.
Yep.
It's amazing. So you can't be sharing a cone beam with the endo department because there you're taking X-rays throughout the procedure. You don't have to take that many in
Right. Right.
orthodontics.
Different
So
software, like you said, different software analytically.
yes, life is too short. I'm kind of taking the step back from that battle, and I'm just
Mm.
kind of trying to get an article out every 6 or 9 months. Um, I'm pretty sure I'll be hosting some students, residents, or interested practitioners at our office. We've got a
Awesome.
great system working between the pediatric office and the orthodontic office. We have a morning shared huddle where we talk over common patients, who showed up, who didn't show up, who's getting their braces off, who needs this, who needs that. Our office manager regularly interacts with theirs. So we've got a great working relationship. It started with me renting a couple of
I
chairs.
was going to say, do you think you would have taken this leap and ended up here had you not? You think you would be where you are on interceptive treatment had that not been the path you followed with going more?
No,
Interesting.
no. This is why I'm still doing this. And
Mm.
I told my business partner at the time, I said, at my age, if I went to my accountant and lawyer and said, "Hey, I got this idea. Should I do this?" and asked for their advice, they'd say, "Are you kidding? Get better at golf and get lost."
Yep.
So, and I told him that too. I said,
Yeah.
this is crazy, but I love it.
Yep.
I have a great demographic. The population around my office is just the best.
Mm.
They're highly educated, working people that just appreciate all the time we spend for them. He's got a great practice. We've got a great practice. And we were fortunate. I think I told you that during COVID, the gym next door went bankrupt.
Mm.
We expanded into the facility. So now we've got a 2,500 square foot orthodontic clinic that
Mm.
we've pretty much outgrown. I mean, we could,
Wow.
if we wanted to, we could just keep going,
Yep.
and it's great. I love it.
Yeah, and that passion is something I think there's a lot of orthodontists have lost their passion or are so stressed, and there's a lot of stresses on us in our practices today more than ever with all the different avenues we have to have mastery in, and things coming at us and the challenges associated with that. And I found for me that interceptive treatment and what you were saying a little bit ago about the parent standing up in the clinic that anybody who's done this has had, or the kiddo that runs over and gives you a hug afterwards and they feel better about themselves, they look better, they're breathing better, they're sleeping better, they're doing better in school. All of these things make you really enjoy your day. Days can be really hard in our profession, and you stress a
Well,
lot.
not to mention the fact that in my busy first 28 years in Tucson, it was a bread and butter, 100 and some patient a day practice. When I started, or when I had the Scottsdale practice, I basically bought a failed orthodontic department from a corporate office that was wanted to get rid of them. So I moved it into a vacant space. It was in a part of Scottsdale that was a mature part of Scottsdale, not a ton of young kids. So I had a lot of adults, a lot of second opinions. Every dentist up and down the street was doing Invisalign. So it's just kind of stressful. I was very fortunate. I was doing well, but that wasn't how I wanted to finish up my
Mm-hmm.
career. So we sold it to a group, and that group sold it to another group. Everybody was happy. So that's good. The one thing that I want to mention is that now that I do phase 1/phase 2
Mm-hmm.
and or comprehensive and or parents,
Mm-hmm.
life has been simple. I
Mm.
mean, if you
Yes.
get if you get to control transverse from
Yes.
day one, the rest of your life is easy.
I'm so glad you
When I
said
was
that.
in my Scottsdale practice, I had a lot of adults, a lot of parents. Most of them had teeth removed.
Mm-hmm.
Most of them didn't have enough transverse width. I
Mm-hmm.
tried to suggest Sarpies and say, well, do the best you can without doing what needs to be
Yep.
done.
Yep. Yep. Huh.
And
Yep.
and that's how I lost my hair.
Yeah.
It was awful.
Yeah.
Now I'm in control of the
Yes.
situation from age 7 or 8. And phase 1, 12 to 15 months, phase 2, 12 to 18 months. Yes, there might be a couple extra months as opposed to getting in there with self-ligating and elastics everywhere and this and that and maybe some TADs. But the orthodontics is so much easier.
Yes.
It's just,
I'm so glad you mentioned that because
the
it is.
orthodontics is so much. Nothing scares me. My new patient coordinator came from a practice in California, and she commented, where are all the impacted cuspids?
I
I
was
s-
waiting for you to finish. I was literally going to say to you, how many
Yeah,
impacted canines are you seeing now?
not many.
I was
And
literally,
if we
yes.
do have them, it's
Yep.
because, well, how come our dentist didn't say anything?
Didn't say,
Well, they
yep. Didn't
just
see it
took
soon
bite
enough.
wings for 10 years.
Yep.
So we've got a couple, but they're coming in from someplace else.
Yep.
But as far as patients that we are in charge of, we rarely have an impacted cuspid.
Agreed.
And there was a lecture from you know the expert on impacted teeth from Israel. Um, I can't
Cure
think,
all? Cure all? Is it?
no, I can't think of his name offhand. Um, but anyhow, he has a lady associate in the practice. She spoke at the AAO Early Treatment Conference probably 5 or 7 years ago,
Okay.
and I screenshot all her slides. And she makes a comment right in there. Preventing this stuff does take a little bit more time,
Mm.
but it does prevent the morbidity at the end. And so she makes no bones about it that for some patients, they might have a few more months of treatment
Mhm.
than others, but she's so committed to doing this that she just thinks it's worthwhile. And I do too.
And isn't preventative? Oh, doesn't preventative always take a little more time? I don't know why in the orthodontic world we're so hypercritical of maybe an extra. I mean, if you take the time to eat right and exercise and live a healthier lifestyle, that takes time, energy, and effort. And the
I
result
agree.
is you have lower incidence of heart disease and complications, health complications later in life. If you want to train for a particular race or marathon, right? And or you're going to train for a particular event, you have to put time in to master that. If you just went, you could just go out and run it, but you're not going to have the level of success, or maybe you make it, but you're not going to have as great or as successful of an outcome. So the precedent is there clearly in society in so many ways that if you put the time and energy in proactively, right? Proactively, you may have to spend a little more time and energy, but the outcome will be superior. And I don't know why in orthodontia, it's all about, well, it took you, between your two
I know.
phases, it took you 28 months. And I just treated that case in 22 in one phase. Number one, a lot of those people aren't also counting the stuff you talked about earlier. Maybe they start with a little 2x4, a lingual holding arch. They
Yeah,
don't
right.
count those months. It's conveniently when the full braces go on. But even if they did effectively have only 20, say 22 months, I've treated cases that way. And I considered myself a fairly competent clinical orthodontist. I was good at what I did clinically. I could never get the results as predictably and easily. And not even that I couldn't get them, period, but as predictably and easily as when I do a phase one proactively on that same case early, right? That didn't get sent to me, unfortunately, at 11 or 12. But when I saw them at 6 or 7, if they needed it, again, there's plenty of patients that don't need it, but we're talking about patients that do need it. Go in, develop the arches, expand the arches, normalize the transverse, which, as you said, is such a huge component of what we do and often overlooked, and then let them grow. And then if they need, some don't even need a second phase, but if and when they do, align everything, get the occlusion to fit ideally. It's so predictable. You get a superior outcome. The aesthetics are better. The function is better. It's a better journey for the patient. And truth be told, there's very few of those cases that had you let it go and done nothing, or extracted teeth because of the crowding, you could have treated in the same amount of time or less, when you really look at it. And that's speaking personally to treating thousands of cases these ways. And you have to look no further than in a lot of residencies, how many cases are passed from resident to resident to resident year after year after year. And it's
Go
not
on.
right. And it's not necessarily because like the residents weren't competent or didn't know. They've got faculty observing this and helping them. It's because it was misdiagnosed and because
Yeah.
they treated it reactively, not proactively. That's the person trying to run the marathon that's, falling over and cramping up every because they're stumbling over themselves and they can't get across the finish line. If they had trained and had the right proactive approach, wouldn't be as big of a deal. Hey everybody, be sure to check out the Doc website where you can get access to tons of great information, including free educational content, access to private one-on-one coaching with me, ADA CERP recognized CE courses, and amazing patient testimonials. Just go to theorthocoach.com. That's theorthocoach.com. And now back to today's episode.
I don't know if this is the time to bring this up or not, but there's a common misconception that addressing the transverse with expanders opens the bite irreparably, I have not seen that as a
Me neither.
problem.
Me
I,
neither.
I was taught in residency, well, what's the mandibular plane angle or the
Mhm.
NSGOGN? And I
Yes.
wouldn't use an expander here.
Yes.
I haven't been tracing x-rays for years. Like I said, I've been working on looking at the face, working
Same.
myself inward, looking at the angulation of the upper and lower molars, the
Same.
lack of curve of Spee or Wilson or whatever. And if you get the maxillary base to where it belongs
Yes.
and you upright the lowers to fit into it, and if you can get rid of the habits, things fall together.
Yes.
And it's as simple as that. So that has not been a stumbling block for me, because I know I've heard it from young residents that'll visit the office and they'll say, well, aren't you worried about it? I don't want to be cavalier and say that I don't worry, but
Mhm.
I'll deal with that if it appears, and it just doesn't seem to be a big problem. So that's one misconception that I think is out there, that, well, you got to look at all those, you got to take out teeth if there's an accentuated curves, and it's actually getting rid of those curves. And that was
Yeah.
that was a difficult thing for me to do, because I was, a trained prosthodontist where we lived on curve of Wilson and curve of
Hmm.
Spee and balancing side contacts and mutual protected occlusion and all this
Hmm.
kind of stuff. And I thought, well, you can't do this. You're going to flatten the curve of Spee, but it magically works.
Yes.
And that's kind of one of my comments I want to leave from this.
I completely agree. I find it actually makes it easier. Things would just work themselves out. And I know that doesn't sound like a very educated way
No, it
to
doesn't.
say it. It's like it just works itself out. Well, great. Like that's super technological and advanced in your with all your all the years we've both spent in school to just say it works itself out. But ultimately it does. When you normalize the transverse, when you address the curve of Wilson, the curve of Spee, and you normalize the growth. And again, you're making more room for the tongue and the airway. So now they're breathing better, they're sleeping better. So their growth does, you don't see these patients. I would be shocked. Some of these patients that showed vertical growth indicators early, right? Say 7, 8 years old, they're growing vertically, they've got the antegonial notching and a steep mandibular plane angle. And I would go fix the transverse and it would redirect their growth. And
Yes.
right. And you're thinking what you said, which is what I was taught too, that wait a minute, expansion's supposed to open the bite and hinge the mandible downward and backward and cause all these other issues. And I'm thinking, wait a minute, by normalizing the transverse, this kid, and I have pictures in my courses and slides that I go through to show the changes in the vertical of these patients pre and post treatment, 14, 16 months apart or 12, 16 months apart. And I always say to people, do you think if I left this exact same patient and did nothing to them, but let's say extract teeth or just sort of watchful waiting, as we'll call it, do you think they would look like this patient 14 months later and that would have that change in redirection of growth to the vertical? Of course not. Of course not. So, again, it doesn't sound too shiny or fancy to say it works itself out in that sense, but it really does. It really does. But again, you're treating the etiology. So the science behind it is you go in, you address the transverse deficiency. And I want to also add, neither of us are saying, or I don't want to put words in your mouth, but I'm certainly not saying, and I don't think you are, and speaking with you and reading your publications on this, that you go and take a patient who's broad and wide and start blowing out their transverse just
No.
because now that's what you do. Like, and that sadly, are there some people I think who do that? I do think sadly, and that gives all of us who really believe strongly in the value of early treatment a bad name. But that's not what we're saying. It's no, if they are narrow, address it young. It's so much easier to address this before the adult teeth come in. And as you, and I love, and I did not know that about you. I think it's so awesome when I mentioned the quote from Edward Engel from '07. We've known this for a long time.
There's another paper mentioned in one of my articles from Rose, who is an anthropologist, who talked about the fallacy between the teeth are too big for the jaws. Actually, it's the jaws that are too small for the teeth.
Yes.
That's a great article. And then a shout out to James McNamara. I started my career with McNamara and the Frankel appliance, and he was traveling the globe trying to figure out how these things worked. And I probably am finishing my career with James McNamara because of his articles on addressing the transverse and his lectures at the AAO meetings, showing how widening the maxilla allows for the mandible to come forward, the old foot
in
and
the
shoe.
shoe. Yep.
Yes. And I have screenshots of his slides also showing parents that. And
Yep.
I don't think I went to that lecture. I was there live. I was kind of skeptical. Oh, that can't work. And then you start doing it and you say, darn, if there just aren't as many class 2 patients in our practice.
Yes.
They were class 2, they're not, or now they're rubber bandable.
Yep. Yes.
It's amazing how ahead of everything he has been, and really not pushing it on anyone, just saying this is what I do, and take it for what it's worth. And I fortunately had the opportunity to put it into place. And the one thing that he does that I don't do, that I probably should do, is expand the lower first and widen the upper to the target.
Yep.
But from a practice management point of view, parents come in thinking you need the expander, and they say, "Oh yeah, you need an expander. We're going to start with this lower Schwartz appliance." They kind of look at you like where are you coming from? So I mean, I eventually get to the lower, but I don't start there just because I haven't been known for that in the past, and you have to kind of move yourself in that direction, I think.
Yeah.
So it's plus removable appliances to start are a headache. When I do the expander, the 2x4, I put brackets on the upper. At that point, I ask the parents, Do you think your kid would wear a retainer on the lower that's removable? I personally like it the best because I think you really get some nice width pretty fast. But if we're going to be, losing them and you're going to be fighting with him and taking out the college fund every time they, lose their retainer, I don't want to go there. Then we'll
Mhm.
just do like a Arnold, or we'll just put braces on, you
That I
know.
was just going to say, I've got to get you take it. I was the same way. So when I figured this out, because I didn't learn it in school, I studied a lot of McNamara, and I'm glad you brought him up on this because he's one of the few too in academia who has even dared talk about mandibular expansion. I mean, there aren't
Right.
many. Schwartz and Gratzinger talked about it in the 60s when they put this forth, but there are very few academicians who have gone out and put themselves out there. And McNamara's got some great articles in the 90s on Schwartz Appliance. I think they were with Bichetti, I believe. But he talked about using the Schwartz as well. And I started doing it with that way 20 years ago. And same as you, it was just a battle, and kids were losing them, or they'd come in with
Yeah.
them and they would have like been turning it, the parents take it out to turn and tell the kid to put it back in. And the kid comes in, oh, I'm wearing it's falling all out. So I
Yeah.
made what I called a Williams, which is like a fixed, lower expander. It's basically like a Schwartz that's kind of like, think of a hybrid between a lower holding arch and a Schwartz. So
Yeah.
it's a lower holding arch with a higher rack screw essentially. And I know some people use like an Arnold expander, and there's different ways to do it. So I did that, and I would use upper expander for them. And then won't go into it on this episode, but talked about it in the past and in my courses, how I evolved about 6 years of doing that. And I just got really tired of all the headaches of expander issues and emergencies and all of those issues. And I evolved into doing it all with braces and wires. And as long as you start them young, you're not doing this on 10, 11-year-olds having this predictability. But if you get these kids in that 6 to 8 age range and you put them in upper and lower full braces and disocclude the arches properly, which I'm simplifying it now. There's a lot. I
Yes.
had a lot of learning curves and things that I did wrong, but I mastered that approach. And oh my goodness, you talk about beautiful arch forms and easy for the patient, and it all happens at the same time. And efficiency for your practice. I mean, you literally have a bonding appointment, 4 or 5 visits during treatment, and a debond. And I mean, that's it. There's no SEPs, there's no turning instructions, there's no RPE checks. So that was my next phase of transforming how I did this. And I treated thousands of cases that way. And it's gonna, won't go into detail on it now, but I'll have to. We'll stay in touch. If you could do it, simplifies and the parents and the kids love it. It's fun for them. There's no discomfort. And I think the best part about it, which I didn't know at the time when I was exploring this area and doing it, but I've since realized it was the tongue had space. So as much as those braces and wires were doing some of the work, they were just initially getting some of that dental alveolar compensation, because I would see patients come back after 8 weeks in an 014 NiTi, and they would have arch development and width. And I'm thinking, what is going on? And a lot of that, looking back, and this palate would start to change shape. And I have pictures I show at my courses before and after at every visit throughout the treatment. And you would all of a sudden see this high vaulted palate starting to broaden out. And why? Well, the braces were just starting to initiate that expansion process, probably a lot of it dental alveolar and those early light wires, because you're not even getting up to like a quad helix force yet. And then the tongue gets in there and does its thing. And tongue being, it's quote Stacy Ochoa, nature's expander, right? Goes in and starts to grow and expand that maxilla and mandibular arch. And next thing you know, all you need is like a 1622 NiTi, maybe 1725 in some cases, maybe a little steel with a little expansion in those really narrow maxilla cases. And you do it. So yeah, so it's made it even more fun for me since I went into that arena, because it just simplified everything.
And we haven't gotten into the tongue tie yet either, have we?
No, yeah, that's a whole nother
That's a whole nother
side
topic,
of it.
but
Yeah.
I feel very strongly that a lot of people can benefit from having their lingual freedom released. The struggle has been follow up. You almost need pre-surgical physical therapy, meaning tongue exercises.
Yep.
You need post-surgical physical
Yep.
therapy, meaning tongue exercises, which causes a lot of them to get like medium results or
Yep.
relapse.
Right, because all of a sudden, once it's released, I was gonna say that is there's just like so much tongue to deal with now
Oh
that
my
they can't
gosh.
control. Yeah.
And another point that I think made with you when we discussed things earlier was that when I do have a patient that I've decided to place into phase one, I pretty much won't let the patient leave the room until I determine, why is this kid narrow?
Mm.
And there's
Yeah.
almost always a
I
reason.
love it.
And
Yeah.
oftentimes in the cone beam and the sagittal view, you'll see the tongue down and back,
Hmm.
big void between the palate,
Yep.
roof of the
Yep.
dorsum of the
That
tongue.
V-shaped invagination on
Yes.
the dorsum. Yep. Yep.
And I mentioned that to the parents, and we talk about that. And I'm just now getting to the point where in our phase one records, we're seeing if we've created more room for the tongue to go there. If it's
Yep.
still hanging down low, we kind of revisit the lingual frenum release.
Yep.
Um, that's a whole nother topic.
Yeah.
Uh, well, there's a nurse practitioner in the area who was one of my very, very, very first patients in the late 80s.
Hmm.
Who, presented to the office, quick view, four buys out. Uh, she has no airway. I mean,
Hmm.
she actually went and got her license. She now has uh, a tongue tie practice,
Well.
realizing that breathing, airway, nasal cavity space is the key. And
Hmm.
she said, I know you did what you were supposed to do.
Right. Right.
You did. So there's no hard feelings, but she saw it and decided to go down this path of working with all kinds of lactation specialists
Hmm.
and restorative dentists that actually refer patients to her to have adult tongue ties released. So
Yeah.
I haven't seen enough to be sold on it for so many people, but
Hmm.
I think a lot of people could benefit from that.
Yeah. I think that's such a great way. I actually want to. I think that's a great point to finish on. Is there's even though you and I have spent the last hour plus talking about how passionate we are about this and how much we've seen and done, we still acknowledge there's more to this that we don't even know that we're open to learning about or figuring out, such as tongue ties, myofunctional therapy, earlier treatment, right? Going in some of these patients. I know
Yes.
people who are going in 4 or 5 years old with these patients and using things like Invisalign first to go in on these younger kids. And people say to me, oh, isn't that, Mike, isn't that just crazy to go in? And I said, well, why is it crazy? If you're solving it and this child is having a response and you diagnose the etiology, then maybe something with the tongue or the expansion young, or maybe you detect something because you're looking at these kids younger that you can send them to the ENT or the allergist for at a younger age. And I think that's where our profession needs to do better. I think we need to stop arguing over teeth. And I think we've spent a lot of years, a lot of decades um, arguing over the teeth and the occlusion, and we know that pretty well. I feel like as a profession, we've got the tooth straightening side, biomechanical side. Obviously, there's new ways to do it all the time with plastic and so forth, and different types of brackets. But the biology of tooth movement, and someone who's trained by Charlie Burstone, I mean, that's
Oh
been
yeah.
there. We've known that for a while now. I think we need to take the next step in our profession as a profession of orthodontics and say we're more than just tooth straighteners. We have more knowledge of craniofacial growth and development than just about any medical or dental provider out there.
Absolutely.
We see kids, we know kids. We need to start seeing kids younger, and we need to push the envelope of what we can do and get away from the dogmas of this, even phase one, phase two, right? That we use those terms as well. I mean, we're all used to those, but why don't we look at it as treating the patient in a continuum for a series of years? And I think a lot of it, maybe it's harder to bill that way. We don't know how to get a 5-year-old in our chair and what to do with them. But we need to push back on our profession and say it's time for the leaders in our organizations and in our schools to start to figure this out and advance our profession. And we get so concerned about the next over-the-counter aligner company that's going to come in and try to
Oh,
steal
I
a couple
know.
patients who are undercutting our fees. And we get so concerned about that. And I'm not saying we don't need to discuss that and that it's irrelevant. I'm just saying, where's all that time and energy into trying to figure out how to treat younger kids? I would just like to see a fraction of it go to saying, hey, we're more than just people who straighten teenagers and adults' teeth. So I'll give you the last word on that to kind of close up. What do
Well,
you,
well,
what do you
I
feel?
agree, and I sat at a breakfast meeting at a AAO meeting. I think it was maybe the winter meeting
Mm-hmm.
with some of the trustees at the AAO, and they were very concerned about losing the vast majority of orthodontists because of all these other meetings that were popping up. And I kind of defended that. I said, well, if the national meetings are like a rehash of the same speakers, the same thing, and every year you're going to start seeing some of these things. And thankfully there are some meetings that are popping up. I still attend the AEO meetings and
Mm-hmm.
the midwinter especially, not so much the national anymore, but um, I think it's almost up to orthodontists that are passionate about these things to kind of create, specialties were created by groups of practitioners.
Great point.
Or the orthodontist didn't become the first specialty because the ADA said so. There was a
Great
bunch of
point.
orthodontists that said we need a specialty, and we became one. And there's of course a lot of politics in that. So I think it does take some relatively well-versed and educated people who document their steps to stand up and say, this is benefiting people. And you also mentioned the thing about how do you bill for this? That's always a problem, because I guess the AAO is now working with the ADA to get some different codes, and what are they? Fortunately, we've never had to, a small percentage of our total income is insurance codes. So that's always kind of good. Yeah, I don't know. I'm just passionate. I'm going to keep writing. I'm going to keep doing my thing, and I'm thankful for the work you're doing and exposing us all. And it's all good.
Yeah, and I appreciate it very much. And please keep writing. I appreciate you taking your time to come on the show and talk about this, and your passion, especially later in your career. You could very easily just be like, yeah, I'm kind of doing this, but later in my career, I don't want to go talk about this as much. So I give you tremendous credit for that. And to have passion later in your career, period. I think a lot of people are just kind of looking to wind down. And I think we have so much to learn, myself more in the middle ages of my career. But especially the younger docs, have a lot to learn from the people who have done this for a lot of years. And especially someone like yourself who's done it in so many different capacities and has continued to grow and develop for the benefit of the patient. And so I really hope everyone can take that message to heart from our discussion today, and continue to read your articles, and please keep putting that out there. And really, I just want to extend a heartfelt thank you for being on the show and for sharing all that.
Thanks for having me. All good.
Yeah, appreciate it. Thanks so much, Dan.
Okay, good.
All right. Take care. Thank you for watching this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses, or to schedule a private one-on-one coaching session with me. And remember to join the Doc community on Facebook for more great content designed to help you succeed both personally and professionally. Just go to Facebook, search for the Doc community, and request admission into the group. You can also find Doc on Instagram at @theorthocoach. And always remember, you have been blessed with the ability to do amazing things.